Welcome to the latest edition of the ACRO podcast. Today, we're very pleased to present content in partnership with one of our corporate sponsors, Myriad Genetics. And in recognition of Family History Month, we're excited to have this programming focused on genetics and the latest discoveries in that arena. Today's host for our podcast is going to be Dr. Albert Attia from Mayo Clinic, a member of the ACRO Finance and Development Committee. Dr. Attia, thanks so much for being our host today. We look forward to the program.
Thank you. Thanks for the intro, Fraser. We're pleased to have Dr. Lee, Dr. Chris Lee, here on the podcast to talk to us about, genetic mutations and different factors that can play a role in both the diagnosis of cancer as well as the treatment. Just a brief background about Dr. Lee. He earned his medical degree with distinction in research from St. Louis University. He then went on to train at Huntsman Cancer Hospital and the University of Utah Medical Center, where he garnered multiple national awards. He also published many articles in many of the leading journals, such as JAMA, JCO, as well as Cancer. Dr. Lee remains very active in the promotion and development of modern radiotherapy techniques for both prostate, brain, head and neck, lung, breast, and gynecologic malignancies. Welcome, Dr. Lee. Thanks for joining us today.
Thank you. Appreciate being a part of the discussion.
So, in line with the Family History Month, how is both germline and somatic testing change your medical practice, say today versus 5 or even 10 years ago?
Yeah, it's a great question. Cancer patients today, of course, are very well informed as a general rule. We have, compared to 10 years ago, patients with internet and patients just seem to be much more well-informed and involved in their care and researching and finding out about their disease and options that are available. And in addition to that, I find that when I meet with patients on a daily basis, there are a lot more questions nowadays that are focused on genetics. Patients often come in and wonder if their diagnosis is going to have an impact on the risks for their kids. They wonder, how it's going to impact their treatment or how they're going to do with treatment. Both germline and somatic testing, of course, can impact not only the risks or chances of developing cancers, but impact the specifics of their treatments in a variety of ways. So it really has changed.
Yeah. So on that note, let's take a few examples for our audience. So, for example, with prostate cancer, could you share with us kind of a few settings or examples where that's had an effect on the patients in terms of their counseling, both for their families as well as their treatment decisions?
Yeah, so just to take a few examples, I often have patients who are coming in to see me who have a new diagnosis of prostate cancer. And we sit down with them and we talk with them about what led up to their diagnosis. We talk about their biopsy and their Gleason score, what their PSA is, and looking at those. Often they have imaging studies that have been completed before they come to see me, or they have questions about that. And so, along with just talking about their initial diagnosis and options that are available for them for treatment. Now it's very common for, as I mentioned earlier, for patients to bring up the question, well, I have sons or daughters, how does this increase their risk of cancer? Or often, it's weighing on patients' mind, for example, if a few years prior, for example, they had a brother who had prostate cancer. And so now there's two family members in that family with the same diagnosis. There may be nuanced differences, of course, but both diagnosed with prostate cancer, and that raises the red flag in their mind of, is this something that runs in my family? Is this something that runs in my genetics? And again, with people being, with all of the different genetic tests that are now available, people can walk into a supermarket or into a drugstore, and they can pick up a genetic test and send off for it. People are much more informed about the impact of genetics on disease, and so these questions come up.
Absolutely. And I think for our audience, if you could explain kind of the difference between germline testing versus somatic testing, because in my practice, I get this often, for example, if we order, Oncotype, Prolaris, Decipher for prostate cancer, for example, patients will, immediately assume that this is some sort of test to see if this is inherited or genetic. Could you explain a little bit for our audience the difference between germline and somatic testing?
Yeah, that's a good clarification to make. So when we're talking about germline testing, we're talking about the genetics that came from your mother and father, your genetics that are familial, that are running in your family. And so that's, that's the genetics that you're born with. So that's the germline aspect. And many germline tests now can be done with just looking at a blood test. For example, someone could do an Oncotype blood test and look at their germline tests. But when you're talking about the somatic testing, then you're looking at actually the difference in the genetic makeup, potential mutations that are present in the genetic makeup of the cancer cells. And so, of course, we know cancer cells have, by definition, they're mutated cells from once a normal cell. And so those mutations are called somatic mutations, and they can tell us a lot about the cancer. They can tell us how aggressive it is. They can tell us about potentially what treatments can be utilized for that test. Those somatic mutations can also help us to subdivide and categorize those types of specifics of the cancer for better research studies and better testing in the future to develop new treatments.
For sure. And even germline testing, I think, has some potential to affect, treatment decisions. How much of a role does that play? For example, if someone has a germline mutation that suggests some sort of radiosensitivity or TP53 or Lynch syndrome, how does that change your approach from a radiation perspective?
Yeah, so as a radiation oncologist, of course, we're also involved in multidisciplinary teams with surgeons and with in prostate cancer realm, of course, with urologists and in addition to medical oncologists who and so we work in these multidisciplinary teams. And you're right, there are specific mutations that cause us to pause and cause us to have further discussion on how to proceed. And so Lynch syndrome, for example, those patients have higher risk of colorectal type cancers, and so that would be a situation where if we're about to embark on a prostate cancer treatment with radiation, for example, we often have that discussion with the patient and make sure that they've had a recent colonoscopy, for example, and have had recent screening tests done, and that they understand what that means for them and what that Lynch syndrome diagnosis genetic mutation means for their family. In addition, the TP53, albeit rare, of course, that's something that of course, we want to know about and can affect treatment outcomes and can affect the types of treatment strategies depending on that patient's also overall health and other comorbidities. And all of these things play a role, but the more information we know about each individual patient, of course, it helps us to better arrange and organize their treatment for today, as well as be aware of what risks may be in the future and how to best predict or be prepared for and screen for those types of issues that can come down the road. And so it allows us to not only speak about the now, but also to kind of look ahead and work with the patient and our multidisciplinary team, their other care providers, on how to also look at also potential risks in the future.
Yeah, and so along with the somatic testing, that certainly plays a role as well in the types of treatment that we recommend. I'd like to maybe use breast and prostate as an example, since these are some of the more common cancers that folks will probably either have a friend or a family member who's gone through this, and what this information can be used for, and how helpful it is, and how necessary it is in making treatment decisions.
Yeah,
if you could comment on that a little bit.
Yeah, the question is very relevant, because right now, as you're aware, there are many ongoing research studies looking at the impact of these genetics on targeted therapies and other treatments that are in the lab right now being focused on, that are in development. But specifically, to take an example, someone with metastatic prostate cancer, for example, who has metastatic cancer, for example, that could have spread to their bone or other organs and is no longer responding to hormonal therapy. If that patient was found to have a BRCA mutation, BRCA1 or BRCA2 mutation, for example, then there are specific treatments called PARP inhibitors. These are specific drugs that are targeted agents that can work well in that specific scenario. And so as the knowledge deepens and more of these links to genetic mutations and specific treatments that can target those mutations are developed, it allows us to individualize the treatment to be specific, kind of like a homing device specifically for that specific cancer's mutation, and to take advantage of a weakness.
Yeah, absolutely. Sometimes I get this across in the clinic, or maybe it can be information overload. What's your experience been with patients? You mentioned that they come in well prepared, having read online. Do you feel like sometimes the overload of information can lead to analysis paralysis, or maybe, or sometimes requesting over treatment? What's been your kind of experience with that?
Yeah, it's a good analysis paralysis. I think we all see it in our own clinics, and probably all see this and do this in our own families, as people in our own families are looking at different illnesses or different medical challenges. There is so much information, and the volumes of information that are out there, no one can really read it all. And so a lot of it is, I think, providing clarity to patients when they come in and meet with us on where are the best sites, or where are some sites that we recommend, websites, for example, or what are the resources that we have found to be most useful for patients in their scenario and in their situation. I find that a lot of the support groups also that are available in our area, that are, for specific patients with certain diagnoses, breast cancer support group, prostate cancer support group, it can be really helpful also for people to sit down with others who are, facing the same dragon right now in their lives. They're asking the same questions and doing the same types of research. And we have, of course, as patients get more comfortable with what they face, and time passes, then it allows us also to focus on some of the nuances, and to as they become more educated in their cancer diagnosis, then it also, I think, with time, they're able to also better parse out the relevant information and separate it from the noise.
Yeah, I agree. I tend to find that the more informed the patients, the less stressful I think the experience ends up being overall. I mean, I think maybe there may be a little bit of initial stress with the information overload, but as you mentioned, it's our job to kind of parse things out and clarify and make it clear for them. I feel with that they feel a little bit more comforted and can attack. And I always tell my patients this. I feel like sometimes you can have a terrible diagnosis but a well-informed patient, and that tends to go more smoothly than, say, sometimes a great diagnosis and a less informed patient, and that can almost sometimes be very challenging. And I think educating the patient is key. And just so for our audience to have an understanding, I mean, us as radiation oncologists, we tend to be seen later on in kind of the process. Who do you think, in your experience, has been more active in ordering these types of testing? Or do you order them yourselves, or as a group, or how has that been working for you?
Yeah, and I think that the answer to that question is probably unique or specific to each region or each area. There are some communities where, and I think probably by and large, the majority of the communities, these tests are ordered by medical oncologists or urologists, and specifically for prostate cancer or genital urinary type malignancy. But in our region, then oftentimes patients already have this information. They already have had it ordered by the urologist or medical oncologist. But I do order a fair number of these tests also from patients who come from outside institutions, or they've had for example, they've had a somatic test done, but they haven't had a germline test done, or vice versa. And so it goes back to also, I think, that volume overload. Sometimes it's helpful to get this information step by step as the information is becoming more and more known about their situation, rather than order 10 tests all at once, and some of them you may not need for that specific situation. But I find that over time, with that evolution of understanding of their situation, and of course open discussions with the patients and their families about what information do they want to know, what would be helpful for them, what would provide them with, as you mentioned, stress management, what would help them to relieve their stress in their situation, which pieces of information would provide some of that comfort in a very inconvenient and very uncomfortable visit. Of course, nobody is excited to come in and talk about these things, but we're here to help.
Yeah, absolutely. And then what about in terms of prognostic type testing, Oncotype DX? You may have hinted at that a little bit more, or Prolaris. Could you go a little bit in depth in terms of how that's used in your practice and what decision making is done there, in terms of what patients should undergo?
Yeah, so as a radiation oncologist, I use the Prolaris test quite often in patients who have a new diagnosis of prostate cancer. It's biomarker testing. It's looking at cell cycle proliferation genes, and it can give us information specifically for patients undergoing radiation treatment on the relative benefit of adding hormonal therapy to their prior to or with their radiation treatment for definitive treatment or curative treatment for prostate cancer. Yeah. And so I find that to be very useful, and it provides the patients with individualized statistics for their situation, and allows us to have a very educational session about the risks of their diagnosis, and with treatment, what their what the statistical outcomes look like for their Gleason score and PSA and so forth, those clinical factors in addition to that biomarker testing. The Oncotype DX is more in my clinic. It helps me more to inform the patient of other potential risks that they have in their germline or in their family genetics, if they have additional risks down the road of other cancers, or, as we mentioned before, Lynch syndrome, to make sure that they have an up-to-date colonoscopy, for example.
Yeah.
But of course, when the disease becomes metastatic, then that can help with decisions if they have BRCA mutations with, as we mentioned earlier,
Systemic therapy, yeah.
Systemic therapy. But we find these variety of tests, they're useful in different situations along that spectrum of very early, very curable cancer, all the way up to some very aggressive metastatic cancer that may not have a cure, but patients can do well for many years nowadays because of all of the variety of new wonderful treatments that are available that weren't available 10 years ago.
Yeah, I agree. I feel like as our field continues to evolve, these types of testing are going to play such a critical role in how we diagnose and treat. I always tell patients I feel like it's a bit naive to think that we can put cancer into 4 buckets: stage 1, 2, 3, and 4. I think as these tests evolve and improve, we'll be able to give patients more, for the cliche term, personalized, treatment. I agree. Yeah, and I think to your point, I think ultimately, I think patients do find this helpful, and I think, my personal experience has been that it's I think useful information. If you could shed further light, and then in terms of what you would recommend for someone listening to this who maybe doesn't have a cancer diagnosis, what should they do with this information, or how, what are some things to keep in mind as we kind of wrap this up?
Yeah. These are great discussions to have. I tell patients, the cancer treatment today is not the same as the cancer treatment that your grandmother or that your grandfather had, 15, 20 years ago. This is, everything is evolving, and genetics, I think, is a take-home message. The genetics that you were born with, as well as those somatic mutations that can occur through life, play a role and are very important for patients as well as for their care providers to understand how that can better tailor that treatment to their needs. And this is an evolution. I would suspect that in 10 years from now, we're going to look back and we're going to say, wow, what we knew then was nothing compared to what we know now.
Right.
The way that things are evolving so rapidly, it's a very exciting area of oncology, and has the opportunity to impact lives to in a huge way. So that's exciting for us to be a part of as care providers. And I think for family members and loved ones, as they're hearing or listening to this podcast, I think it should give hope. It should be exciting to hear about these advancements and how it can help tailor, their or their family members' treatments, and exciting to look ahead to the future of all of these new innovations that are happening.
Yeah, absolutely. And I think it's helps raise the question if the patients, say, has a diagnosis of cancer and are not getting these tests, maybe it's a good conversation point with their oncologist, and maybe can just to get more information. Agreed. Well, thank you so much, Dr. Lee, for joining us today, and I'll just leave it open-ended if there's anything else you'd like to add. Otherwise, we'll wrap this up.
No, I appreciate the discussion. Thanks for hosting the discussion, and I think this is a wonderful topic to focus on.
Yeah, I think hopefully we can do many more. I think there's a lot to delve into here. Thank you.